Roger, thank you very much indeed for your kind welcome, and I'd like to thank Dr. Cantor and the Cantor Charitable Foundation for their support for this important global webinar. If I could have the next slide, please. Now, and then I'm AJ Kakar from London, and I'm now going to move on to my next slide, if I may, and introduce the rest of this panel who are going to look at questions with regard to cardiovascular disease, because I'm joined by Professor Barbara Cassidy from Oxford, who is Professor of Cardiovascular Medicine there in the university, but also President of the European Society of Cardiology. Professor Shirinath Reddy from New Delhi, who's President of the Public Health Foundation of India, and Professor Sam Goldhaber, who's Associate Chief and Clinical Director of the Division of Cardiovascular Medicine and Head of Vascular Medicine at the Brigham Hospital and Harvard, and Professor of Medicine at Harvard Medical School. So welcome to all of my panelists, co-panelists. Next slide, please. And we're going to hear from the panelists in a moment, but I think that there are a number of important questions with regard to cardiovascular disease and COVID-19 that have become apparent during the period of this pandemic. And I think there are four important questions that we'd like to address over the next 30 minutes or so. What is the significance of pre-existing cardiovascular and metabolic comorbidity in terms of a risk factor for COVID-19 outcome? What have we come to understand about the problem of intravascular thrombosis, both small vessel thrombosis and large vessel thrombosis, both venous and arterial, in terms of the natural history and clinical outcomes for COVID-19? What have we observed, and how might we prevent in the future the detrimental impact on those with existing cardiovascular disease in terms of mortality and morbidity, with regard to how the health system has had to respond to becoming principally a pandemic treatment system? And what are some of the short and now increasingly better understood medium and long-term consequences in terms of cardiovascular health of infection with the SARS-CoV-2 virus? I'm going to ask each of our panelists to make some opening remarks, and then we'll go into a discussion session. Barbara, if I could turn to you first, please.
Thank you very much. And thank you for the invitation, and also to the Cantor Foundation. Dr. Cantor, I really do appreciate your words. So I'm going to talk about what have we learned in terms of cardiovascular disease and COVID-19. And when we started at the beginning, the data from China really identified patients with cardiovascular disease as a prime target for a very severe disease and for mortality from COVID. So the good news is, next slides, please. May I have the next slide? Yeah, that's it. The good news is that once one corrects for age, the effect of which is absolutely staggering on mortality for cardiovascular disease. Please look at the first line. If may I have if you can click again, I have three built here. So here is the effect of age, and this is in a log scale. So if anything is underestimated by this graph, and once this is corrected, the cardiovascular disease is corrected by age and others, then you can see that the risk, the increased risk is there, but is much smaller, and is much smaller than one conferred by obesity or by social deprivation. If I may, if you can click again and again. Or indeed even male sex. These data clearly show that the effect of the COVID on cardiovascular disease, if anything, it's not direct, which would be consistent with the data from autopsy that haven't actually environment of the COVID infection on the myocardium, unlike the lungs and some part of the circulation, as we will see later. However, what it is really important is really the effect, the indirect effect of COVID on patients with cardiovascular disease. And so all around the world, there has been reported a reduction in hospital admission in patients with acute coronary syndrome, usually a reduction between 20 and 40% in patients with STEMI, and between 40 and 60% in patients with non-STEMI. And that is at a time where we would expect an increased incidence of acute coronary syndrome, as we normally see with other infectious disease pandemics such as influenza. So this has been incredibly worrying and has been reported widely and has added, I think, to the toll of the COVID pandemic in terms of both morbidity and mortality. In the UK, we have been able to follow this data almost in real time by working in the NHS digital environment. This is something that is very good about the England, where we can have access to this data. And we have shown a 40% reduction in acute coronary syndrome admission in all the 147 acute hospitals in England. That has peaked at the beginning of April. It has started not with a lockdown, which is what a lot of people had suggested, but is really started with the beginning of the language of fear for COVID in the media, which coincided with the first death at the beginning of March. And we have also seen that this has recovered partially following a national campaign. So it is also good to have this data to follow the impact of an intervention. The last thing that I want to say is does this matter? It does matter, because we have seen both in Italy and in the UK that part of the excess mortality that we have recorded during COVID, if we can go to the last slide, please. That's it. Is really not due to COVID. So if you could see here the dotted line as the expected mortality, and then the large circle as the mortality observed, the excess mortality observed during the COVID outbreak, then really only the yellow part can be attributed directly to COVID. The rest is probably a combination of the disruption of the clinical care as well as other imprecision in coding. But you can see also that this happened in Italy, in the ISTAT data from Italy, where about 50% in Lombardy, where there was the greatest disruption in the health system, about 50% of the excess mortality is not accounted by COVID. So, the indirect effect of the pandemic, in my view, is larger than the direct effect, and that is where we really need to focus our efforts if we have a second wave. Thank you.
Barbara, thank you very much indeed. I'm now going to ask Professor Reddy, Srinath Reddy from Delhi, to give us some observations on the experience in India in terms of cardiovascular outcomes, mortality and burden of disease with COVID-19.
Thank you. Well, clearly, India is currently in the headlines now for the wrong reasons, being third in terms of the number of cases and being the fastest in terms of the rate of rise of cases. But if you actually look at the adjusted rates for the population of India, we have about 1,040 cases per million and about 24 deaths per million, which is on the lower side. And one of the reasons that's attributed for the low death rate, apart from some possible undercounting, is that we do have a much younger population with only 10% of the population being over 60 years of age. Nevertheless, we do know that despite the younger age profile, many people who are fairly young, especially in the middle age group, are having a very high burden of cardiovascular risk factors as well as cardiovascular disease and diabetes. If you look at the statistics before COVID, the mean age of onset of myocardial infarction in Indians is about 52 years, whereas it's about 62 years in Europe. There's a very high prevalence of diabetes, hypertension, and cardiovascular disease in the 35-year plus age group. In the past 20 years, urban diabetes has risen twice from 9% to 17%, and rural diabetes from 2% to 9%. Indeed, in the capital city of Delhi, 25% of the people above the age of 20 years have diabetes, and 47% have pre-diabetes, and in the age group of 40 to 49, 40% have hypertension. So it's not surprising, therefore, that the COVID deaths are also associated considerably with comorbidities, especially cardiovascular and diabetes, in a younger than expected population. About a third of the deaths are in the age group of 45 to 59 years of age, and many of them have manifested comorbidities. While obesity is clearly not that high as per the conventional criteria, visceral adiposity or central obesity is very high, and that is associated with the metabolic syndrome and dysglycemia and dyslipidemia. And therefore, we do find, while the admissions for elective cardiovascular procedures and diabetes-related complications have come down during the COVID phase, among the people admitted with COVID, we do find a fair amount of cardiovascular manifestations in the form of myocardial infarction, ischemic stroke, and deep vein thrombosis, all of which represent a hyperthrombotic state or an unstable cardiovascular plaque in the coronary arteries. And therefore, anticoagulants are being used routinely, prophylactically, and those in the intensive care in a therapeutic dose range. Out of hospital, of course, we are likely to see many elective procedures being stalled. We do not yet have a clear count of whether out of hospital cardiovascular deaths of people who could not make it to the hospital have actually increased. Those data are still being gathered. But one of the interesting things that has happened is that there has been a legislative change, because many of the people who are staying home and are unable to access services in hospitals previously could not access telemedicine services because the Supreme Court of India had banned it, saying that no doctor can actually prescribe a medicine unless he has examined the patient. Now, with the COVID situation, that legislation has actually been passed now, which enables telemedicine to be extended much more widely. And therefore, many of the patients with hypertension and cardiovascular disease are paradoxically benefiting in terms of their routine and chronic care from the assent given to telemedicine. And this is probably likely to be a feature that will stay with our health system. But one of the interesting aspects is that thus far, it's mostly the urban areas in India who've been affected. 2/3 of India is rural. The cardiovascular risk factors are there and are rising, but much less than in urban areas. And indeed, till recently, hemorrhagic stroke has predominated over ischemic stroke. Will the entry of COVID-19 to rural areas change that situation, with a hyperthrombotic state being superimposed on rising rates of diabetes and hypertension, and put even the rural areas very much in the picture of coronary artery disease, arterial and venous thrombosis? We'll have to wait and see. But certainly, COVID has provided us some challenges in the area of cardiovascular disease as elsewhere in the world, but we do see it at a much younger age than elsewhere in the world. Thank you.
Thank you, Srinath. Now, I'm going to turn to Professor Sam Goldhaber from Boston. Sam, to talk to us about COVID and principally thrombosis.
Thank you very much, AJ. And I want to thank the Royal Society of Medicine and the Cantor Foundation as well. Next slide, please. Well, I'm going to go across this slide to explain the relationship between COVID-19, hemostatic abnormalities, and adverse cardiovascular clinical outcomes. On the left-hand side, you see that most of the COVID-19 patients have underlying comorbidities. They could have some underlying acute illness, or they could be bedridden. In particular, simply living in a long-term care facility, these patients constitute more than half of the deaths in the United States. And relative to today and this symposium, chronic obstructive pulmonary disease, heart failure, also very important predisposing factors. And as you go down this first column, we see that the inflammatory response to acute respiratory distress syndrome causes both endothelial dysfunction and superinfection. We see that tissue factor increases, tissue factor inhibitor decreases, the number of lymphocytes decrease, inflammatory cytokines such as IL-6 and C-reactive protein increase. And inflammation, of course, begets myocardial infarction, stroke, pulmonary embolism, and DVT. And in the middle column, we see that, in fact, the hemostatic abnormalities do include pulmonary microthrombi, and I will say also macrothrombi, myocardial injury, increase in cardiac biomarkers such as troponin, and the D-dimer goes up, as do the fibrin degradation products, and the platelet counts decrease. And what is the clinical outcome seen in the far right-hand column? Venous thromboembolism, myocardial infarction, stroke, and occasionally disseminated intravascular coagulation. Next slide, please. This comes from an autopsy of a COVID patient. In the upper left-hand panel, you see the lungs. This patient passed away with lungs that were enlarged 2 to 3 times their expected weight. And just below this, you see a transverse section of the heart. And on the right-hand side, we're actually looking at right ventricular hypertrophy, not left ventricular hypertrophy. And in the right-hand side of the slide, we see one of the very typical findings of cardiovascular disease in patients with COVID-19. At the white arrows, you will see these small pulmonary thrombi that form. And we think a lot of them actually form in situ rather than being embolized from the deep veins. Next slide, please. And here you see a thrombus in the pulmonary venule. So COVID-19 keeps us guessing, are we going to have micro disease, macro disease, or both? Next slide. The coagulopathy from COVID includes the decreased platelets and increase in D-dimer, and also increased factor VIII levels. These, of course, are non-specific, but taken in context, they can be helpful. Not only in diagnosis, but of course, we're interested in prognosis and early accurate triage of these patients either to being able to go home and waited out in quarantine, which is the case for us in about 90% of patients, or hospitalization, where in hospital about half of our patients go to the intensive care unit, and of those, about 80% require mechanical ventilation. And the others at least start off in a step-down unit outside of the ICU. But I can tell you one of the very vicious aspects of COVID is that one's clinical condition and course can change very quickly, and these patients can be stable and then rapidly decompensate. Next slide. So this is a multi-centered French hospital study looking at COVID patients triaged to intensive care units. These patients had acute respiratory distress syndrome, and there were 150 such patients placed in the intensive care unit, and they were all receiving some degree of anticoagulation, varying from prophylactic doses to therapeutic doses and sort of an in-between half dose. And of these 150 patients, 62 had clinically important thrombotic complications, 25 with pulmonary embolism and 3 with DVT. Usually, with venous thromboembolism, about 2/3 of the cases are DVT, and only 1/3 are pulmonary embolism. But in COVID-19, the majority of the thrombi are pulmonary embolism thrombi, not DVT. These patients often required dialysis at the bedside. They were too unstable for hemodialysis over 3 or 4 hours, so they would get continuous dialysis. And in 28 of these patients, the circuit for the continuous dialysis stopped working due to thrombosis. 2 of these patients were receiving circulatory and ventilatory support on ECMO, and 2 had thrombotic occlusion of the pump. And let's not forget about the arteries. There were 2 strokes. One patient had peripheral arterial thrombosis, and one had mesenteric arterial thrombosis. So you really see that COVID can inflict a wide array of thrombotic disorders. Next slide. Well, I think that to summarize the venous thromboembolism in COVID patients, and I think VTE is the most common thrombotic manifestation, we see that pulmonary embolism occurs much more frequently than DVT, that the rate of pulmonary embolism in COVID ICU patients can exceed 20% even with VTE prophylactic anticoagulation. For reasons we don't really understand, many of these patients will have in situ thrombosis rather than embolic thrombosis, and we find microthrombi not only in the lung arteries but also in the venules. And what we're studying intensely now is breakthrough VTE that occurs throughout the hospital in the COVID patients despite standard doses of VTE prophylaxis. During the height of our COVID surge in Boston, we found that empirically that the standard dose of low molecular weight heparin was not preventing VTE in the intensive care unit, so we empirically doubled that dose for all patients admitted to the ICU. But it's clear that there's more that we don't understand about COVID-19 and thrombosis than we do understand. It does provide us with the opportunity for the community to come together locally and at the global level with conferences like this one to share each other's experiences. Thank you.
Thank you very much, Sam. Let's now move to a discussion. And thank you for your contributions. Look, let's pick up, Sam, where you left off in terms of preventing and managing thrombosis. You speak about doubling the dose given of low molecular weight heparin for prophylaxis. What thought has been given about the potential contribution of the activation of coagulation early in the natural history of the disease, soon after infection with the SARS-CoV-2 virus, and the potential benefits of intervening at that stage with prophylactic doses of low molecular weight heparin, akin to the perioperative experience we have over many decades?
Yes, well, it would be best if we could predict in advance who's going to suffer COVID, because we know the infection begins about 4 or 5 days before the onset of symptoms. And so if we can predict with some reasonable accuracy who is going to suffer COVID, we could certainly consider anticoagulation prophylaxis earlier on. But in fact, in most patients coming to hospital, their initial chest X-ray shows a very fluffy bilateral pneumonia, and by that time the coagulation system is in full revolt, and the way it revolts and tries to protect us is by upping the clotting, and then it does become very difficult. But I think, AJ, your point about early intervention, in surgery, you always give the first dose of a prophylactic heparin prior to the skin incision. If we could strive for something like that in COVID-19, we'd be better off.
Barbara, you highlighted the concerns that we have in terms of later presentation of cardiovascular disease during this period in time. In terms of the broader, and Shrinath picked up on this as well, in terms of preparing the population to live with the risk of repeated waves of SARS-CoV-2 infection, what do we understand about trying to more aggressively target comorbidities that drive poor cardiovascular outcome? Indeed, we've seen today in the United Kingdom, or in England, a launch of a new emphasis on trying to target obesity in the community.
Yes, indeed, obesity, as I have shown from the data that comes from electronic health record from general practice, it's a very important risk factors for COVID-19 mortality. So that would be, if you like, a non-pharmacological, ideally, intervention that would have a big impact. The other factor is age. And so shielding really should take age into consideration, probably more than any other of the risk factors that we have listed there, with the exception perhaps of people who receive a transplant that seem to have a very high risk, and people with recent hematological malignancies. But otherwise, I would say that diabetes and obesity are very important, and this also comes out from the death certificates. Cardiovascular disease, the rate of cardiovascular disease in the death certificates between COVID and non-COVID deaths is not different, but diabetes and obesity are. So it does show that there is an enrichment for this risk factor in the COVID deaths.
And sure enough, you highlighted, of course, the younger population in India, but still in that context, the importance of prevalence of cardiovascular risk factors in a younger population. What lessons do you think will be learned in health economies and environments such as India with regard to the population impact of COVID-19 and its intersection with cardiovascular health?
In fact, it's not just COVID, but if you look at other types of infectious diseases, viral infections like influenza, H1N1, we find that every time there is an epidemic outbreak, it is people with comorbidities and the elderly who often have comorbidities who are the people who are most likely to succumb in terms of mortality or extremely severe illness. Therefore, for any kind of viral outbreak, as illustrated vividly by COVID, but also applicable to other viral diseases as well, I think the lesson to the health system and to the policymakers should be that we need to reduce the burden of diabetes, hypertension, chronic respiratory disease, obesity, including visceral obesity, and then take policy level actions as well as health system level actions in order to reduce the burden of these, because these are going to be actually predisposing people to more severe forms of disease as well as higher mortality. One of the interesting side effects of the lockdown and even the reduction in traffic post-lockdown has been that air pollution levels came down markedly, and that was possibly the only beneficial effect on cardiovascular system because of better plaque stability. However, I think the lesson is that we ought to be rebuilding our health systems to take better care, both in terms of prevention as well as early detection and care of all of these chronic diseases, which actually set the stage for viral infections to wreak their havoc.
And if we may just finally move to the question of therapeutic interventions. And we've seen principally retrospective analysis looking at the benefits of intervening with anticoagulation in terms of outcome for COVID-19 in the ITU setting. What do we understand about at the end of, let's say, this first surge of disease? What do we understand about anticoagulant strategies for patients in hospital? And what do we understand about those on chronic anticoagulation and their outcome from COVID-19? I don't know, Stam, if you would like to start.
Sure. So I think we understand that we really don't know, and there are multiple clinical trials in progress now, and I think we as healthcare providers should really, when possible, encourage our patients to join these trials so we can get some good data on anticoagulation, and particularly the intensity of anticoagulation. And then we also have to worry about drug-drug interactions. We are now, based on the Oxford study, routinely treating patients with dexamethasone, regardless of their acuity, if they're hospitalized. And how does dexamethasone interact with a lung pneumonia in the presence of a high dose of anticoagulation? We really don't know, and there are many other investigational agents like anti-IL-6, anti-inflammatory agents. What happens when you mix those in someone with high-dose anticoagulation and with steroids? again, there's more that we don't really know with the therapeutics than that we do know.
Sam, thank you very much indeed. I think we're going to have to hand back to Roger Kirby to move on to the next session. I would just end by saying that we've looked here at some of the acute manifestations of COVID-19 and cardiovascular health. There is, of course, the very big question as we now start to follow patients who've recovered from acute infection with regard to the longer term impact of acute cardiovascular injury in terms of an individual's health and performance. And those are matters that need to be subject to very careful research evaluation in large cohort studies, and much of that work is currently being initiated.